Bismillahirrahmanirrahim. Uh, my introduction is here. I am an ex-army officer, a physician and diabetologist. I have a very important topic to discuss today, that is foot examination and how to go from there in diabetic foot. Objective of this program is straightforward. We save the limb because limbs are life, not only for the person who is who lost a limb, but also all the people dependent on him and all who are emotionally and uh, financially dependent on the person. So we save a limb, we save a family. There are certain important prognostic factors as far as uh, this diabetic foot is concerned. But important, there are many important prognostic factors, but most important is end-stage renal disease as far as the patient is concerned. Because by the time patient come to us, they already have developed diabetic nephropathy, and they have already developed certain ulcers in it. We have to see the area, the depth of ulcer, the location of the ulcer. If it is at a pressure point, it is serious because it's very difficult to remove the pressure. If you remove the pressure by certain artificial methods, that is, we provide them with assistance in footwear and with orthodontics, we help them save by that. But they actually aggravate their presence at such pressure points. And how many of the ulcers are there? Because if it's a single ulcer, it's probably one local factor. But if there are multiple, there are probably other things at play. That is blood vessels and blockade of blood vessels and multiple factors, more than one factor are at play. And whether it's infected or it's non-infected. There are certain limb factors involved because arterial supply, as far as peripheral arterial disease is concerned, it causes loss of blood supply and ischemia, and that in itself is a bad prognostic factor. And foremost, loss of protective sensations. If a patient does not have protective sensation, that is pain of ischemia when sitting on a foot for a very long time, or pressure of shoe on the foot, then it's not feeling it. It's going to be very uh, disastrous for the patient because they will not even know and the foot is damaged. Whenever we have a patient with diabetic foot, they come to us, they're usually elderly or they have long-standing illness. And to examine them accurately, we have to relax the patient first because they are usually very apprehensive and they have pain in their limbs in certain areas. When we start examining, they cannot communicate to us properly, or they are apprehensive in telling us that they have pain. They are otherwise afraid of that pain. So there is a psychological component and there is a physical component to that. We have to relax the patient before we start examining the patient. What are the elements of assessment? We assess by previous history. Is there any ulceration? Was there any ulceration in the past? Is there any history of amputation? Does the patient have childhood injuries? Is there any vascular surgery in the past? Or the patient has had an angioplasty? The patient is a smoker? Or there are positive or negative neuropathic sensations? Positive, we all know, pin and needle sensations, burning, shooting pain, electrical sharp sensations. And in vascular symptoms, we have claudication, that is always coming in when patient is moving around, and rest pain when patient is lying at night at rest and there is pain. That is usually indicative of neuropathy. There are non-healing ulcers in the patient, had in the past or had now. So that is important for before we start the treatment. Examination is performed as we do it in other systems. It is to be informed systematically. We inspect people paid. We do neurological assessment, footwear assessment, and general examination. In inspection, we fully examine in a systemic fashion. right, left, top, lower side, sole, dorsum, medial, lateral, and we see skin for any change of color. We see where it is shiny, there is loss of hair and things, or there are trophic changes in the skin. There are corns and calluses to show us the areas where patient is persistently under pressure. And are nails okay or deformed? Is there any edema or deformity? Is there joint movement normal or it is limited? Is there any change of color or there is necrosis, necrobiosis, or whether there are skin spots, which are common in diabetic dermopathy? Patient's footwear is important because it shouldn't be heelless and it should be very high heel. And we have to see whether the shoe is fastened with a strap to avoid slipping, or there are any nails in the shoe. Uh, is the lining okay or is worn out? Is it thick enough to protect the foot? And so on. Are there any seams which are pinching on the foot? We have to examine it very thoroughly and we have to guide the patient accordingly. So then we investigate for ulcers and we investigate neurological, vascular, and skin temperature. This is all recorded. We do lab tests and we do radiology and we check for foot pressure. The radiological assessment initially includes a global inspection, uh, especially in the part which is in between the fingers, because usually that is the part which is ulcerated or inviting infection. Is there any presence of callus, nail dystrophy, or paronychia? It has to be addressed to. Temperature of the skin. Is it higher in one foot than the other? Or are there changes, these changes local or generalized in the foot? Are there any evidences of vascular disease or ulceration? If, if so, we have to send the patient for specialty foot. Musculoskeletal assessment is similarly done, include evaluation for any gloss deformity. There are rigid deformities which are caused by the factors that there are presence of contractures. They cannot be reduced easily. And common forefoot deformities that actually cause increased plantar pressure, result in skin breakdown, and uh, exposing the patient to ulcer formation. That include metatarsal phalangeal joint hyperextension with interphalangeal flexion, which is called clawfoot, or hammer toe with distal phalangeal extension. Neurological assessment is the most important component because that is main or most common part in pathway to diabetic foot ulceration. It is basically to see loss of protective sensation of lobes rather than early neuropathy. We have to look for that. And how do we do that? We do 10-gram monofilament test. We put that filament at the designated points on the foot, all these places where usually there is pressure and patient walks. And we push it enough to give it a bend. And with that flexion, we check for sensation. If there is loss of sensation, for that gives we mark it accordingly, we record it. So we have to advise accordingly. Or then we have 128 Hertz tuning fork test. For this, we check vibration sensation against a bone at various points on the foot. And this actually tells us the loss of myelin sheaths, vibration sensations, large fibers, main neuropathies. We accordingly, sorry, or accordingly we check with plethysmometer, plethysmometer to check for the sensations by giving it a pressure and above 25 hertz pressure, 25 volt pressure, that sensation is not there, we know that it's because of uh, diabetic neuropathy. So how do we treat them? Treatment options for diabetic foot infection is by using giving them various severity grades. If it is uninfected and wound is without purulence or inflammation, we treat it in outpatient with topical antibiotics. If it's grade 2, that is ulcer, purulence with more than 2 centimeter, less than 2 centimeter around the ulcer, we check that there is no skin or subcutaneous tissue infection, no abscess. So most of them are not limb threatening. We just give them oral antibiotics, that is cephalexin, trimethoprim, methylphenidate, levofloxacin, or amoxicillin clavulinate combination, or clindamycin, and we treat them in outdoor. With moderate uh, level of infection, that is not life-threatening, but it is limb-threatening infection as above, with cellulitis of more than 2 centimeters around the ulcer, and there are streaking or deep tissue abscesses. There is gangrene, and with some life-threatening involvement of muscles, maybe. So some are life-threatening in these. We give them accordingly antibiotic as of above, but with uh, we can switch over to according to the severity, ceftriaxone, linezolid, or teripanem, or tripasrin, clavulinate. With severe infection, they are life-threatening, which is infections plus systemic toxicity signs or metabolic instability. Systemic toxicity signs we all know: fever, chills, tachycardia, hypotension, confusion, vomiting, etc. And if there is hyperglycemia and acidosis or azotemia or hyperglycemic coma, the patient is in very, very dire need of urgent care and requires ICU management. Along with that, give the sporting treatment for life and same treatment with antibiotics. As far as the neuropathic pain is concerned, we have two options. That is, one is for focal peripheral neuropathy. We give local treatment, that is lignocaine or TENS, and this is transdermal electrical stimulations, nerve stimulations. And we give 30 minutes a day, or we give lignocaine patches. That is for first degree. This is first line treatment. Then we go for second line treatment, that is capsaicin patches or botulism toxin. That again is effective in certain cases or may not be effective. We can give for other peripheral central nervous system pain or focal pain. We can use SNRIs, which is duloxetine, venlafaxine, and gabapentin. We can give tricyclic antidepressants, or we can give combinations. Or we have other choices. If we have a second line, we advise them physiotherapy along with oral drugs, that are a combination of pregabalin and tramadol, or combination therapies. If patient is not responding or severe enough, then we refer them to pain clinics for spinal cord stimulation and further management with that. So, in nutshell, uh, main key components of drug diabetic foot examination summary includes skin examination, that is skin status, color, thickness, etc., sweating, loss of hair, infections, checking between the toes for fungal infection, ulceration, callus, blistering. As far as the musculoskeletal examination is concerned, we have to look for deformities, fixed deformities, and muscle wasting. Neurological examination is done by using 10 gram monofilament, vibration using tuning forks, pinprick sensation anti-reflex, or along with bioplatus monitor. And we can do vascular assessment with foot pulse examination and ABI if indicated. With that, I come to the end of my lecture. Thank you very much.